Two, one. Please start, sir. We are live.
Very good evening to all distinguished delegates and our today's eminent speaker, Dr. Vinodh Kumar sir. I am Satish Rama Joshilkar from Zydus Life Sciences. Honored to welcome you all for the scientific feast called CLEARTalk. On behalf of Zydus Life Sciences, I would like to express my most sincere gratitude for your presence in this scientific webinar. Giving a just brief about CLEARTalk. CLEARTalk is one more initiative and facet of Unite Against Dyslipidemia. As you know, in India, 7 out of 10 patients are uncontrolled on LDL cholesterol. And the recent development in the field of management of dyslipidemia, bempedoic acid, is an add-on choice for LDL cholesterol management. Hence, this session of Clear Talk is focused on the most recent development in the field of dyslipidemia, that is late-breaking clear outcomes trial on bempedoic acid, which was presented in ACC 2023. And we have today's eminent speaker, Dr. Vinodh Kumar sir, to give a way through on bempedoic acid on clear outcomes trial. Sir is a consultant interventional cardiologist at KIMS Ashilfa Super Specialty Hospital, Perinthal, Manna. Sir has many publications in national as well as international papers, like Indian Heart Journal recently published Myocardial Performance Index paper. Sir also presented various posters, paper presentations in Tamil Nadu CSI, recently conducted Tamil Nadu CSI, a case on rare and complications of common surgery, interesting case studies of syncope, and so on. Sir is a well-known faculty and speaker in most of the leading CMEs and conducted by major pharma companies. And he is a very well eminent speaker for today. And we, as a Zydus, would like to thank you, sir, and welcome you for this clear talk. And hope your clear talk will clear all our doubts on bempedoic acid. So thank you so much, sir, for being here. And over to you, sir.
Good evening, all. Thank you so much for the nice introduction. We'll straight away go to the topic. My slides are changing, right?
No, sir. Just click on the screen and change.
Okay. Yeah. Coming to today's topic on bempedoic acids. Bempedoic acid is the lenses of clear outcomes trials. So before going to the main topic and trial, just few points on what is the relations between LDL and cardiovascular events reduction. So for each 1 millimole per liter of reduction of LDL, there is certain percentage of reduction of cardiovascular events. Like each 1 millimole per liter when converted to milligram means it comes around 38.67 milligram per deciliter of LDL reduction. There are certain percentage of relative reduction of cardiovascular events. And this reduction also increases with increase in number of years. Like you said, in a 1-year trial, the reduction percentage of reduction is 11%. The number of years is increasing, like to 5 years or 6 years. The percentage reduction is at most 36%. So there is 6 years, there is 1 millimole of reduction of LDL, the cardiovascular events. This reduction is 36%. Coming to the risk of non-fatal MI and cardiovascular death and stroke in percentage over a period of 5 years treatment, like from 1 millimole to 5 millimole. If there is a 5 millimole reduction over the duration of 5 years treatment in patients with cardiovascular disease with diabetes mellitus, the risk reduction is 62%. If we go to same 5 millimole with patients with cardiovascular disease and with metabolic syndrome or impaired fasting glucose, the risk reduction is 32%. Without cardiovascular disease, with only patients with diabetes, dyslipidemia, and these patients is treated for over a period of 5 years with reduction of 5 millimole per liter. The risk reduction is 16%. So there is significant reduction of relative risk and percentage of non-fatal illness and cardiovascular death and stroke over the period of 5 years. If the treatment is continuous beyond 1 year, the risk reduction percentage increases. As number of years increases, the number of risk reduction of cardiovascular events also decreases. So coming to the management of dyslipidemia, the first line of drug of choice, high on priority to statins. But what is our concerns? Whether all statin users achieve their target LDL levels as per guideline recommendations. And our next concern is whether how to achieve these LDL targets after the patient is getting a maximal tolerated dose of statin. So these two are our main concerns we are going to see today. If patient is in statin therapy, whether they are achieved to the target LDL levels along with maximum statin therapy, we are going to see. So our first concern, target LDL level according to the guideline recommendations. So these are this called meta-analysis regression flow. So the lipid lowering therapies is differentiated into two therapies like statin therapy and non-statin therapy. So there is number of trials conducted with statins and non-statins. Mainly statin, there are 25 trials which conducted on lipid lowering therapy and percentage of cardiovascular risk events are assessed. And coming to non-statins, fibrates, niacin, and acetamide, dialysis sequestrants, and PCSK9 inhibitors, all comes under non-statin therapy. If all these 49 trials are grouped into the meta-regression slope, comparing the relative risk of major vascular events on one side and the percentage of relative risk reductions on the other side, and the percentage of LDL levels achieved by these trials is, if you put it in the chart, it comes to around the statin with all the 25 trials as a monotherapy, the percentage of LDL reductions comes to 0.8, 0.9 millimole per liter, and the relative risk reduction is 23%. So the relative risk reduction per 1 millimole reduction of LDL is 23% when coming to statin therapy. Coming to non-statin therapy, significant relative risk reduction seen in PCSK inhibitors, where two trials is 4-year trial and ODC trial recorded the events. As lower the LDL level is better is for longer duration of PV reductions. So this is the target guidelines proposed by European Society Cardiology 2016 versus 2019. So before going to the target LDL levels, what are these low risk, moderate risk, high risk, and very high risk group? We come to the target level after discussion with the risk factors. So major atherosclerosis cardiovascular risk factors. Age is more than 45 years in male and more than 55 years in female, and there is family history of premature atherosclerosis cardiovascular events, and current cigarette smoking, high blood pressure level, and low HDL level. So these are the 5 major atherosclerotic cardiovascular risk factors. And supportive high risk features are diabetic, CKD stage 3-4, familial hypercholesterolemia, and calcium coronary risk of more than 300 pounds per units, and non-stenotic carotid plaque, a lipoprotein more than or equal to 50 milligrams per liter. See, these are the additional high risk factors along with the major ASCVD risk factors. Coming to the non-conventional moderate risk factors is coronary calcium score 100 to 299 and carotid intimal thickness plaque increased a lipoprotein A level of 20 to 49, impaired fasting glucose, and hypolipoprotein B100, a level of more than 110, and the pleiotropic and high sensitive CRP level more than 2 is considered non-conventional moderate risk factors. So what is high risk? If there are 3 or more major atherosclerotic CVD risk factors, that is called as comes into high risk. If it is 2 high major risk plus 1 high risk or plus 1 non-conventional moderate risk, this comes under high risk. If it is 2 major atherosclerotic CVD risk factors, this comes under moderate risk, and 1 it comes under low risk. So with these risk factors and classification risk factor, the target levels that is proposed in the 2016 ESC guidelines is for low risk, the target is of LDL level is less than 115 milligram per deciliter, and coming to moderate risk is the same as less than the target LDL level should be 115 milligram per deciliter. And for high risk patients, the target LDL is less than 100, and for very high risk patients, the target level is less than 70. So after the guidelines, now the recent the 2019 ESC, when coming to 2019 ESC guidelines, the target levels of LDL is totally changed. Where for low risk is the same as 115, for moderate risk is 100, for high risk is LDL level should be less than 70, and for very high risk, the LDL level should be 55. There is a disproportionate gap between the LDL target levels between the ESC 2016 guidelines and the ESC 2019 guidelines. So this gap is very studied and published in the Da Vinci study. So the main the protocol of the Da Vinci study is how these gaps, if patient is taking the same statin therapy, but the target levels are changed according to the ESC 19 guidelines. So these gaps should be adequately met. So this we will publish in the Da Vinci study. We'll come discuss it detail in the coming part. So as the CV risk increases, the need to reduce of LDL will be more. So based on revised ESC 19 guidelines, how many patients have controlled LDL? These with the targets of according to 2016, those who were considered as controlled LDL level, but coming to 2019, they were considered under not control. So how this gap should be met? So the Da Vinci study conducted in across 18 countries in Europe, where the primary and both secondary prevention of patients are included, of total of 5,888 patients. The primary prevention patients are 3,000, the secondary prevention patients are 2,888. So the Da Vinci study states that the statin usage in all patients, which includes both the primary and secondary preventions, you can clearly see that the red mark is 27.6% who is taking the statin monotherapy for control of the target LDL according to 2016 guidelines. So if these guidelines is considered, these target levels of LDL is considered to be according to 2016, only 30% of achieved their this chart shows the dark red shows the target level of LDL according to 2016, and this lined lines showed the target level according to 2019. So those who are considered 53% according to 2016, it shows that only 30% on statin therapy though has LDL level control. So as per revised guideline from ESC 19, 27.6 eligible patients are receiving high incidence statin, only 30% achieved their target LDL levels. When it comes to the high risk patients, only 37.5% taken the statin monotherapy, and only 22% according to 2019 guideline are under LDL control. With this 37.7% with statin monotherapy. What this Da Vinci indicates that along with statin monotherapy, some more drugs to be added to get the target level to control according to the 2019 ESC guidelines. That's what this Da Vinci study states there. So what additional drugs can be added along with statin monotherapy apart from statins? The next prescribed class indication is acetamiprid, and next drugs goes to injection PCSK9 inhibitor, which is economically high, and it is injectable form where most of patients are reluctant to take. The next class indication is bempedoic acid. Bempedoic is the novel drug with the mechanism of action of ATP citrate lyase inhibitor. So Bemdac acid approved in US, Europe nations, and India in 2020, and main indication of approval of this Bemdac acid drug is those patients with uncontrolled LDL with maximum tolerated statin dose. Bemdac is indicated, and high risk patients with atherosclerosis CVD. Bemdac is indicated, and familial hypercholesterolemia patients also is indicated. Our next major indication is statin intolerance, or whom the statin is contraindicated. This bempedoic acid drug is indicated. Coming to the mechanism, it has a novel mechanism of action. It inhibits the ATP citrate lyase enzyme, which is the pro-enzyme to convert into citrate into acetyl-CoA. This acetyl-CoA is further acted by HMG-CoA synthetase and reductase to form the cholesterol synthesis. HMG-CoA reductase are inhibitor by statins, with acetyl citrate lyase is inhibitor by bempedoic acid. Bempedoic acid is a prodrug which is actively converted into bempedoil-CoA only in the liver. The conversion enzyme present only in the liver, which is not found in skeletal muscles. So skeletal muscle side effects are totally decreased when coming to usage of bempedoic acid. Bempedoic is a prodrug activated in liver. The expression of ACSVL is seen only in liver, not in skeletal muscles. Coming to the excretion, bempedoic acid mostly excreted through kidney, and there is mild inhibition of OAT2 ionic transporter of kidney. So most of the side effects are due to this OAT2 inhibition. These ionic transporters are responsible for uric acid excretion through kidney. So inhibition, bempedoic will inhibit this. There is mild elevated of serum uric acid, and further it leads to gout as well. And this O2 inhibitor also is the main mechanism is there is some excretion due to other statins, like apart from atorvastatin, rosuvastatin, simvastatin, pravastatin are excreted through there is mild this OAT2 transporter. Inhibition of this transporter leads to elevated levels of simvastatin, pravastatin in the blood serum, which cause the musculoskeletal defect when these drugs are used along with bempedoic acid. Coming to the half-life, 21 hours, more or less 70% of total dose is excreted through kidney. So, but even 70% of excreted through kidney, there is not the necessary adjustment of dosage is needed in renal impairment patients. There is no specific trial in patients with end-stage renal disease. Along with this, there is no dose requirement in hepatic impairment. Also, but child PET class 3 is not studied, no studies. So serious monitoring is needed in patients those have previous history of high hyperuricemia, serum uric acid level elevated, a previous history of gout, or patients more than 60 years, or patients taking corticosteroid, or fluoroquinolones, or renal failure, or history of tendon rupture. There is serious monitoring of this record in these patients. So these patients are more at risk of inflammation of tendinitis leads to tendon rupture. Bempedoic is totally contraindicated in patient with more than 60 years who is taking steroids and fluoroquinolone with the history of tendon rupture. And as we discussed, the dose of simvastatin more than 20 mg and pravastatin more than 40 mg leads to the deleterious effect of these statins in the muscle. So these totally contraindicated in patients taking simvastatin and pravastatin. It can be safely used along with atorvastatin and rosuvastatin, even if it is a high-intensity statin. And pregnancy, it is contraindicated, and in lactation, it is contraindicated. Coming to the CLEAR outcome trials, which is recently published in April 2023. So before going to CLEAR outcome trials, what are the trials we have previously known for bempedoic acids, where the CLEAR Wisdom and CLEAR Serenity all are bempedoic acid trials along with the statins showed significant reduction of LDL level, and the clear harmony and clear tranquility where the LDL levels at 12 weeks, that is significant reduction of LDL. These are without statin conducted in a statin intolerance patient. Similar to these, the clear outcomes also conducted in the statin intolerance patients, those who have elevated LDL level. The total number of patients included in the trial are 13,970 patients, and the median follow-up is of 40 months. Both primary and secondary prevention patients with elevated LDL level and statin intolerance are included. And the primary endpoints who looked into the 4 component of MACE events: the cardiovascular death, the non-fatal MI, the non-fatal stroke, and coronary vascularizations. The similar number of patients seen in Jupiter trial also were conducted with rosuvastatin placebo. Nearly 19,000 patients included in the Jupiter trial with significant reductions of the cardiovascular events. Next number of patients increased. See, you can see in the clear outcomes with bempedoic acid in statin intolerant patients. Coming to the demographic data, the main points to look into is the mean LDL cholesterol level is 139 milligrams, with the patients taken into account comparing the bempedoic acid and the placebo. There are few renal dysfunction patients also included in the study with the EEG for more than 30. So both these data is more important because we can see that the end of the result there are few rise in creatinine level where these renal dysfunction patients also included in this clear outcome trials. And diabetes patients included, and statin use we can see 22% in bempedoic acid and 22% in placebo arm. Coming to the primary results. So in the 4-point MACE events, we can see the 13% relative risk reduction in the 4-point MACE event: coronary revascularization, cardiovascular death, non-fatal MI, and non-fatal stroke events. And there is 15% relative risk reduction in 3-point MACE events that is not included the coronary revascularization, the remaining 4 non-fatal MI, non-fatal stroke, and cardiovascular death. With 3-point MACE event, there is 15% relative risk reduction in the bempedoic acid arm than compared to the placebo arm. Coming to fatal and non-fatal MI, there is 23% relative risk reduction, and coronary revascularization, there is 19% relative reduction in bempedoic acid arm. So coming to the background, statin intolerance, the incidence is 15%. So this prevents the patients to get to the target LDL level and cardiovascular benefits. So next step is to be added estimable along with statin, and next step to be added is bempedoic acid, which the recent cardiovascular outcomes are studied in the clear outcomes trial. The primary and secondary endpoints, as we already discussed, the non-fatal MI, non-fatal stroke, coronary target vessel revascularization, and cardiovascular death, and mortality significant reduction was there. Coming to the secondary endpoints, the key endpoints to look into the first 3 components: the 3-component MACE events, the fatal and non-fatal MI, and coronary revascularization. As individually assessed, these 3 points as a significant reduction of relative risk reduction in bempedoic acid than comparing to placebo arm. The remaining 3 part individually when assessed, apart from the 4 component and 3 component of MACE events, when individual assess the fatal and non-fatal stroke, cardiovascular death, and all-cause mortality, the similar results are seen in both bempedoic acid and the placebo group. As among statin intolerance patients, treatment with bempedoic acid was associated with lower risk of 4 component 13%, 3 component 15%, and MI 23%, coronary revascularization 29% reduction seen. Coming to the reduction of LDL and CRP, at 6 months, there is 21.7% reduction of LDL in bempedoic acid group, and at 60 months, 5 years, there is 26.1% reduction of LDL in bempedoic acid group, and 22.2% reduction of high sensitive CRP, which also adds the pleiotropic effects similar to the statins. Coming to the adverse effects, as we previously discussed, the main adverse effect to look into the hyperuricemia. Gout hyperuricemia seen in 10.9% in bemdac and only 5.6% in placebo arm. And gout, it is 3.1 and 2.1 in placebo arm. Even though it is raised, the significant reduction of gout is almost same in both bemdac and placebo arm. And to the added points, there is some case reports of polylithias also, which is not that much scientifically significant between the bemdac and placebo arm. Leading to the serious adverse effects, the leading to discontinuation drug seen in is similar to both the group is 10.8%. The clear outcome study conclusion states that the bempedoic acid becomes the first oral non-statin and the first ACL inhibitor to demonstrate the statistically significant reduction of 4 MACE events in patients with or who are at high risk of cardiovascular disease death with documented statin intolerance and elevated LDL cholesterol. Coming to the conclusion, bempedoic acid is an effective alternative statin intolerant patients. It is well tolerated and there is significant reduction on LDL 21.7% and CRP 22.2%. All the primary events are met, secondary events are met. It is effective approach to reduce the major cardiovascular events in statin intolerant patients. Thank you. Am I audible? Hello?
Yes, sir.
Yeah. Very short.
Thank you so much, sir,
Thank
for
you.
this such a wonderful and comprehensive presentation. There are a few questions in from audience which we have received. As you rightly mentioned about ESC 2019 guidelines, they are getting stricter. There's one question which has been raised from the audience is how low one can go, means how low LDL cholesterol one can go. Like if one is going and aspiring for 40 milligram per deciliter or 30 milligram per deciliter. So is there any neurological complications you see?
As none of the studies actually mention the lower level of LDL in any of the patients. But as far as our concern, the target level says that 55 milligram per deciliter in extreme risk patient. And with the patient is some frequent monitoring and we get a target of 50 or 55, that is enough. So that is the main maintenance dose of that patient. So we can continue with the same dose. A further reduction of LDL is not much needed. The neurological deficiency, and none of the studies are documented any neurological, if even though high intensity statin along with PCSK9 inhibitors, where there will be reduction of LDL nearly 60 to 70% of LDL reduction will be there. So these studies are not documented any neurological, even the LDL is so that much low. So the target level says that we can maintain at the level of 55 to 70.
Thank you so much, sir. In relation to the same question, the one question is about my patient is having diabetes mellitus. He's a hypertensive patient, and I have put him on 20 milligram atorvastatin. So what should be my target for this patient? His present LDL cholesterol is around 120, and he's talking about asking your opinion that whether should he's increase the dose of statin or should add bempedoic acid.
Here, the patient age is 45 years and the patient is diabetic. So we should assess the ASCVD risk score. We classify the risk score. We classify into if it is 2.5 or whether it is 5 or it is more than 7.5%. If it is more than 7.5%, the patient ideally needs a high intensity statin. The target LDL for these 45 years patient is with diabetes is approximately 70 milligram per deciliter. So increase the dose of statin to the maximum tolerated dose for this patient. and still it is not controlled, we should go for a added therapy apart from statin monotherapy. We should add a estimate even estimate add if the reduction will be 12%. If it is assess the ESVD risk score, if it is more than 7.5%, and we check for calcium coronary index, if it is more than 300, and ankle brachial index, it is less than 0.9. So definitely these patient needs to be strictly controlled less than 55 mg. So we can add on therapy with bempedoic acid also.
Thank you, sir. Next question is about patient safety aspect of bempedoic acid. In CKD patient, how safe bempedoic acid is?
So as studies mentioned, there is no definite data for end-stage renal disease, but EGFR more than 30, bempedoic acid can be safely used. Only things we have to look into the very previous history of hyperuricemia, because most of the patients will have uric acid level also high, and any previous history of low arthritis.
So one more question is about asking about statin intolerance, because mainly this CLEAR outcomes trial was based on statin intolerance of the patients. So how you define statin intolerance in your day-to-day practice, and
So
and and how frequently you see statin intolerance in your day-to-day practice?
okay, so most of the patients we have are for secondary prevention. So coming to statin intolerance, if the patient is not tolerating 2 or more statins, changing statins, patients have more side effects, then we define as statin intolerance, and we can classify into a partial and complete intolerance. For complete intolerance, along with the target level LDL is not reached, patient will have severe clinical symptoms of myopathy and rise of creatine phosphokinase more than 10 above the upper limit level. So these can be classified to statin intolerance. So the day-to-day practice, we usually start with the loading dose of atorvastatin, and for coming to the next to the patient, we usually assess that like transaminase level and creatine phosphate level and symptomatically. And if we statin intolerant, we reduce the dose, and if we reduce the statin dose and add along the add-on therapy. And if he is tolerating, we can do the same dose till achieving the ideal cholesterol targets.
Thank you so much. The next question is about there are trial which is being talked about benefits of bempedoic acid in new onset of diabetes mellitus patients. So it do not worsen the diabetes, or new onset of diabetes is not developed with bempedoic acid as in
Exactly. Per se, the effect on bempedoic acid and diabetes studies are we have not that much data to support whether the diabetics is caused due to bempedoic acid, because most of the studies are along with statin therapy also. So definite diabetes is due to bempedoic acid, we have no that much data. So only bempedoic acid as the primary drug we have seen only in the CLEAR Harmony and CLEAR Tranquility trials, where there is not significant impact glucose tolerance or diabetic data we have seen in these studies.
So these are all questions which were asked, and then coming to final closing remarks from your end, would like to give to the audience so that they will get clarity on CLEAR outcomes and bempedoic acid.
CLEARance, it's one of the major turning trials where if now everyone is looking for an add-on therapy. So apart from statin monotherapy, so in our sedentary lifestyles and lifestyle modifications, which we achieve for target LD level for both primary and secondary prevention. So patients with statin intolerance, we have a add-on drug like STP, but we have supported drugs of bempedoic acid now. So those statin intolerance patients, the ideal to step to the next level of drug with an add-on therapy. Probably the novel bempedoic acids. We have clear evidence in the recent trial. So to maintain target LD well, it will be very supportive to along with statins.
Outsiders exhaust my is very much privileged to express my vote of thanks. I express my sincere thanks to Dr. Vinodh for accepting our invitation and helping us organize this knowledge sharing platform that is on CLEARTalk on bempedoic acid, Bemdac. Sir, I express my sincere thanks to all the delegates for joining and making this session very interactive. I express my sincere thanks to all my superiors, Mr. Mahal sir, Mr. Gogol sir, Mr. Satish sir, and to all the technical team also for rendering all the support needed. So once again, my very special thanks to Dr. Vinodh for such a lucid presentation, such a crisp presentation. Thank you very much, sir. And in future also, we would like to have your your support for organizing such knowledge sharing platform. Thank you, sir.
Thank you so much, Zydus,
Thank you.
for arranging a good knowledge sharing platform for us. Thank you.
Yeah, thank you, sir.
Thank you.
Thank you very much.
Thank you.